Good evening, ladies and gentlemen. By way of introduction, my name is Michael Shannon. I'm Vice Dean of the Faculty of Nursing and Midwifery here at the College. And our Dean, Teresa Frowley, unfortunately is out of the country and extends her regards, as is our Executive Director, Thomas Cairns, who is out of the country and wishes us a lovely evening. I'd like to welcome our fellows, our board members, our nurses, our midwives, and particularly I'd like to welcome Mr. Neely, the President of the College of Surgeons, and also Professor Cathal Kelly, the CEO and Registrar, and some of the Council members. You're all very welcome. And with that, it's my privilege and honour to welcome Professor Mary Horgan. Mary is a consultant physician in infectious diseases and internal medicine at Cork University Hospital. And she took up the role of the 142nd President of the Royal College of Physicians in Ireland in 2017 and is the first woman President in the College in its 363-year history. And congratulations to you, Professor Horgan. So with that, we are really looking forward to your presentation, and I hand the stage to you.
Thank you very much, Michael, and thanks to the faculty, Professor Kelly, Mr. Mealy, for having me here. I actually hadn't been in this theatre before, and I'm envious of your stained glass windows. It's such a nice theatre here. In many respects, I feel a bit of a fraud talking to a faculty of nursing about breaking glass ceilings, because you're the exemplar of how to do it. And we see that throughout our healthcare system, where the majority of our CEOs of our hospital groups are actually women. So I was trying to decide, I'm just back from holidays and trying to decide how best to approach the talk. And, you know, I could have done a lot of statistics and how women really, certainly in our college, where the woman is, is president, and we have 6 faculties, 5 of the deans of the faculties are women. And the majority of our trainees are women. So I think it's not just me breaking this glass ceiling, but all of us as a college. So I thought it would be better for me to give my personal journey of how I reached and fortunately was elected by my peers as President of the College of Physicians, and happened to be the first woman. It was only a matter of time it was going to happen anyway, because there's so many women physicians. You can ask Cathal how many women enter medicine now. It's the not vast majority, but in my day it was 70-30. Now it's the other way around. So I'm going to start my story, and hopefully I'll be able to do it properly. Thank you. So I'm going to kind of give my story through slides. So my grandfather was a GP in Rathdowney, and this is a picture my mother usually takes out when I go down to her, saying, "She's dead, she's dead, she's dead." But there was 8 in my mother's family. My grandmother and grandfather married fairly late in life, but obviously did well, had 8 children, boys on either side, the eldest boy and the youngest boy. And here are the 6 girls. My mother is third from your right, yes, third from your right. So my mother was the nurse in the family, and the other 5 girls were all doctors. So when I grew up, it was like, well, are there any male doctors? A few of them married male doctors, but it was, for me, normal. And certainly I had a mother and father who really instilled the importance of education. I think my father was, you know, a bright person. He was the first person in his family to go to college. He got the Kerry County Council scholarship, himself and Tim Coonahan, who was our professor of medicine. My father did the classics, Tim did medicine. So it's not very long ago that we all got educated. So my mother was the pushy one, my father was the brains of the outfit, so it's probably always a good combination. So for me, you know, I had a lot of role models. My aunts did different things. My aunt, second from the left, was the first properly trained, if I can use that word, anaesthetist in Ireland. She went to the UK and did her training and was anaesthetist in the Meath Hospital, where she was well known to put all the urologists in good stead, which is a good thing to do. So then I have to mention Kerry, because that's where I'm from. So I went to the local convent school there. This is a picture that I took with my daughter Aisling. We were going over the Connor Pass March about 2 years ago with my mother in March. And it was so gorgeous that this is my screensaver. You know, you might talk, as Aisling had just been back from Yosemite or one of those places that I haven't been to, and said, you know, they talk about the States, but this is beauty. And that's what I try to pass on to those trainees who feel that they need to go away for good, is you don't really appreciate how beautiful Ireland is until you go to Missouri, where I spent a while. And I'll talk a little bit about that, where the nearest to the sea was, you know, it's about 1,000 miles away. And of course, what can I say, off we go again on Saturday evening. I'm hoping for the best. I couldn't watch the last 10 minutes of it. I had to go strolling like my father always did. So I was you know, a Kerry girl going up to Dublin. There were 5 of us from Kerry in a class of 120 in UCD, 30% female, 70% male. And the first day I met a few people, and I'll show them in my graduation, and we became friends throughout college. There was a great mixture of the guys from Dublin who followed rugby. I wasn't used to that, being from Kerry. The people who went to, you know, private schools, public schools. It was just a mixture. We're all the same. There was no flashiness or anything like that. And, you know, it's changed quite a bit from that time. But my memories of my time in UCD were and continue to be absolutely fantastic. And once from Kerry, you're always from Kerry, so I continue to go to Croke Park on a regular basis. Thankfully, being from Kerry, you have that opportunity. So I'm going to get on to, I suppose, my choice of career and the importance of role models and people who really instill a love of a subject. And this is Irene Hillary. Irene was our professor of medical microbiology in UCD. And I don't know if she knew it or not, but she gave many of us a love for microbiology. At the time, there wasn't infectious diseases. And one thing I recall in particular was in 1984, HIV had just been discovered, even though we knew about it for a few years earlier. I had one A4 page of AIDS, and I still can remember the picture or the notes I took, the 5 H's: haemophiliacs, heroin users, homosexuals and Haitians. And they were the 4 risk factors for HIV at the time, when there wasn't a lot known about it. But it was an exciting field because it changed, and I'll talk a little bit about how I ended up doing it. So I trained in the Mater, and I'll show 2 photos of me and my colleagues, my friends in college. This one, and in the photo, and I'll show you the other photo too of our grad ball, one of the 4 of us ends up having early onset dementia. So, and Eileen is now in a nursing home, and it just goes to show you it's a roll of a dice. 4 of us there, it could have been any of us. And I think what we learn as healthcare professionals, the importance of our health. We go into work every day and, you know, see people having to cope with things that we kind of get used to seeing. And I think that's why it's important for us to kind of put ourselves in the position of what would they like. So this was our graduation day in June 23rd, 1986. And this was our grad ball. I don't know if it was probably the following night. If I can get it to work, yeah. So this was shown at our 30-year reunion 3 years ago, and one of the guys, who's much funnier than I am, said we were like two bits of tinfoil. So this is me on the left-hand side, and Bridget Byrne, who's an obstetrician and gynecologist in the Coombe. But this was the days of Princess Di, so this was really the fashion at the time. But, you know, we had that really good collegiality. I suppose what's a bit different is that we weren't very diverse. We had about 6 people from outside Ireland in our class, 5 from Malaysia and 1 from Hong Kong. That's how non-diverse it was. But we really did have really good innocent fun at the time, on a low budget. We went. So then I started my SHO years, and I knew I wanted to do microbiology, but I really wanted to see patients. And in those days, there really wasn't any clinical component to microbiology. So I went to my boss at the time, Professor Murish Fitzgerald, who was a respiratory physician out in St. Vincent's Hospital, and said, look, I want to do this, I've got my exams, what do you think? And he said, oh, you need to do infectious diseases. And I said, well, what's that? I didn't even know what it was. So I said, okay, why don't I do that? So I literally picked up the phone, wrote, as you did in the time, there was no email, nothing like that, and got a number of interviews in the States. I decided, look, there was no jobs here, but why don't I just do what I want? Because I know if I do what I want, then I will be happy with what I do. And if I'm good enough, they'll eventually might find jobs back here. So that's exactly what I did. I did a year's microbiology because the fellowship, the way the interviews were done, it just suited me personally to go in 1990. So I should have gotten a picture or a map of the States, but everyone says, where's St. Louis? Over there, everyone calls it St. Louis. So it's about a third the way across the country, and it's about 5 hours south of Chicago. And why did I pick there? Well, this was in the middle of the AIDS era, and if you had gone to either coast, all you were going to do was going to be AIDS medicine. And it was at a time where there really was there was no treatment at all. So really, you were just putting bandages on patients, really, with all their opportunistic infections. So I chose to go there, and Bill Powderly, who was a UCD graduate, was out there too. So and the other advantage too, there wasn't a huge number of Irish, no disrespect to any of you, but it made you kind of really leave your comfort zone and make it out there by yourself. And I think kind of getting on with things in life, it is important to just leave your comfort zone, take your chance, but give it a considered chance in getting to where you want to be. And so this was in the middle of the AIDS era. Now, I would say there's probably 1 or 2 people that don't know all of the people here. I show this to the students when I give my AIDS lecture, and I show them the top photo, and they're kind of saying, who is that? So obviously this is Rock Hudson, and this is, we all knew him, or certainly my mother and your mothers knew him as the kind of icon of, sex icon of the time. But he was gay, unknowns to everybody, and you can see his journey there. He died at the age of 57. I'm 56 now, and I guess at the time I thought that it was ancient. And then you'll all know Arthur Ashe, who died, Freddie Mercury in his heyday, and this is the last photo taken of him, and you can even see molluscum contagiosum then. And Vincent Hanley, who you'll all remember from MTUSA. So you'll be astounded to know that he was 33 when he died. And when he died, I suppose that he was about 10 years older than me, but like 33 when you're 23 is ancient. But this was the face of AIDS at the time. I don't have any women up there, but there were loads of women, and certainly what I learned in my time in the States is that it really transitioned from, a gay middle-class infection to inner-city poor black people, whose often the least of their problems was HIV infection. And you learn to be the voice and advocate for people who didn't have a voice. Another thing I learned, there are a lot of people out there that don't have voices, and I think we as leaders in medicine need to be, and nursing, need to be their voice, and we need to continue to embrace what we have in this country, which is diversity and inclusiveness. And that doesn't, that's not a reflection of what's happening on either side of us, unfortunately, not the people, but the people who govern. But it was a privilege. I mean, honestly, I could write a book on all I saw and the wonderful patients that I learned from. And it was a period of time, if you didn't train in HIV medicine between 1985 and really 1997, you did not have the whole experience of how bad the infection was. How devastating. People used to sell their life policies, get $30,000 and go off and blow it on a nice holiday because it was that bad. But they were grateful for the care they got. They were grateful for the touch that you gave them, for listening to them, because frequently they were shunned by their communities. So it really was a privilege to have lived through and learned so much, but also how people like this helped other areas of medicine, like our ability to understand transplant infections, because the immune system problems are similar. So I was one of the fortunate people that was able to train in this important period of time, and it's changed quite a bit. So then, I was a Kerry woman. Like, we never went to Cork except for the Munster final because we really hated them. So the second infectious disease job in the country came up in Cork, and again, I suppose I'm grateful for the AIDS epidemic in the sense that not only was I able to look after these patients, but it allowed me to get a job. It was the second job outside. There was one in Dublin in the Mater, and I was the second person. So I walked in the door, and a pure 100% clinical post, nothing. No previous, I didn't inherit a service, no secretary, no house staff, no wards. Then I got the Friday afternoon clinic, which I had for 6 years. You'll all know that feeling. And it was interesting for the first little while. It did take people on a while to understand that, you aren't going to get AIDS if you just sit beside a patient. And I was across the way from the paediatric clinic, and the paediatric people were worried that they'd all these gay men and people who got it from drug use, and having the yellow biohazard sticker. It took me about 3 years to get rid of that, but I really did persist and was able to build up a very strong team. And having come from a system in the States where we really valued the clinical nurse specialist and advanced nurse practitioner, I suppose my first aim was to get a secretary, and I had a fantastic secretary for the first 9 years, same person. You had to have a front of house, someone to pick up the calls. I got an SHO first, then an intern, then a registrar. But in the meantime, I had my clinical nurse specialists, and they continued to have two of them that are still the same people, and they are just key to the continuity of care. And it's very much a teamwork. I trust them. They can escalate and access me very easily with any issues, and that partnership and teamwork is so essential to how I certainly function as a doctor and how my colleagues function too. It's all about the teamwork and supporting patients. So after only 12 years of being a solo consultant, I finally got a colleague, which was great, and subsequently got a second colleague. So we have a thriving service that expands also to Kerry. I insisted I also run the STD clinic there, and certainly the rates of STDs went way up once I arrived, not because of me, but because of the fact that the service increased, and we have a clinic also in Tralee. So, and living in Cork was great. It was near Kerry, first of all. It had an airport, and the schools were fantastic. My father said, the teacher, said schools in Cork are the best in Ireland, and they're free unless you choose to go to a school. So my two kids went to the local Mercy and comprehensive school, so I have nothing but good to say about Cork, except when it comes to playing. Well, I don't need to worry these days anyway about Cork GA. The other thing I think is important, again, is getting involved in board memberships or committees, and I did that from an early stage. I probably said yes a bit much, but I'm just going to mention, I suppose, I was on the board of the IBTS in the early 2000s when there was a lot of controversy there, and HPRA. And it wasn't only a matter of giving back to the country that educated me so well, but it was also interacting with people outside medicine and healthcare. I think we aren't very good at doing that. We all like to live in our own comfort zone. But, you meet CEOs of the ESB and business people and accountants and all of that. And while we might have a lot of knowledge about what we do, they look at the same problem in a different way, and it's something I think we could do a lot better and more of in work environment, and for our trainees who really want things that are different than what we want because they're a different generation. I'm just mentioning the UAMS, not because of Brexit or anything like that, but I think we need to, and I did start getting engaged with things outside Ireland, particularly in Europe, and was very involved and chaired the infectious disease part of the medical specialty union over there. So again, it's leaving your comfort zone, going out networking, which is really important. It makes it very easy then to pick up the phone and ask them, can you do this, or or vice versa, and really selling Ireland Inc. I think that's important. We're a really small country, but we're really good at getting out there, communicating and saying how good we are, I hope. I'm only just moving on. This is just a photo of me, the photo shoot that they had as a dean. So the position of dean came up in UCC, and I successfully interviewed for it. I was the first woman dean, female dean. I'd say I was the first Kerry woman anyway. Well, I was the first Kerry woman because I was the first female. But again, it's, I think particularly for women, sometimes they don't think they're as good as they are. And if you get a list in a job description and you go through the list of 10, women will say, I'm really good. No, guys will say, I'm really good at 8 of those. 2. Doesn't really matter. Whereas women will say, oh, there are 2 things there that I can't do. So it isn't that we are any better or worse than they are, or vice versa. It's just, I think our mindset is quite different. We aren't as confident in ourselves as I think our male colleagues. And then, you just start into a new job. You know that everyone around the team that you have has skill sets. Everyone says, oh, well, did you have challenges? Well, life wouldn't be normal if you didn't have challenges or people challenging you. But really, I think if you articulate what you want to be, and for me it was being, initially the graduate entry programme, being the best programme in the country, no offence to RCSI, that you set about, this is what we're going to do and this is how we're going to do it, and let's all go for the same goal, because then people are accountable, but they also can get the credit when things really work out. There was challenges during the time, and, if I didn't know, I go to my mentors and I get them usually from outside where I'm working, to say, well, what do you think? What's the best idea? What's the best approach? And if you need help, call it. I mean, that's the way I work as a clinician. It's the way I work in the College of Physicians now. And don't be afraid to take chances. And one of the things that I did, and again, a lot of this was through networking, going to things within the university where they had this kind of you know, you're in new leadership kind of thing. And I was saying, oh my God, this is going to be a waste of time. So because you're listening to somebody saying, how are you going to do this? But I was sitting beside one of the other new heads of school in finance, and I was there saying, well, why can't we kind of work together and develop some new programs? And from that came 2 new master's programs and a big grant on health economics. You know, people want to engage with healthcare professionals. Medicine and health are very complicated, and they like to be involved. And they, you know, sometimes they'll phone you up and looking for a new GP, so they like that contact for many reasons. So I suppose the next part of my career was, while I'm still half-time UCC, I'm not doing as much clinical work, because obviously you need to be around to look after your patients properly. And it does give somebody else an opportunity to come in and work and develop their skills when I'm gone. So I had the privilege, as Michael said, of being elected by, our fellowship, as opposed to our council, elect us to be elected as the first female president of the College of Physicians, which was great. I suppose the first mistake I made is that I mentioned that I wasn't a feminist, and I didn't mean it like that. I meant more that I am more than happy to nurture and mentor and encourage both my male and female colleagues to get exactly where they want. And I have one of them up in the back there that works with Arnie at the moment. It's, you know, we're all, you know, and I suppose my job at this stage is to try to encourage people to get where they want, firstly. Secondly, to ensure that I pass on the baton as well to my new colleagues, so that the next generation are there to provide the best of care. And you have to remember that Irish doctors and nurses can go anywhere in the world and get a job, and that is no exaggeration. We do it because we're well trained, we can communicate well, we can network well, and I think we appreciate what we have. I believe that my time abroad, many of you will have spent it, was absolutely time well spent, because it opened my mind. It opened my mind from being, I suppose, someone from Kerry, you're really working with, you know, or studying with, I suppose, middle-class kids and all of that, and all of a sudden you went out to the real world where you really saw the real problems that made you appreciate exactly what you had, the support structures you had. And I do think you appreciated Ireland too. We also are good at copying, pasting. I think the Chinese are good at doing it, but gosh, the Irish are good at doing it. They go out there, they get the best ideas, they bring them back. Now there are challenges getting some of those ideas through the health service, but we do manage to do that. We can articulate well. So I believe that my job within the College of Physicians is to do that, pass on the baton, give all our trainees the confidence to get to where I think I've gotten, which I think is a good place, and do that work-life balance. And you know, everyone's work-life balance is different. I mean, I like to work really hard, but then when I like to travel, and when I'm away, I like to have fun. And I think that's for me, it isn't for other people. I also think it's very important that we're the voice and advocates, the safe voice, the reliable voice for what we do. I'm going to end up with this slide, because this is Kathleen Lynn. She's the only female portrait in the College of Physicians. Mine will be around soon, and I'm going to get a really cerise pink dress paint, which I have already, so that when you walk in you won't miss me, because there's a lot of darkness and redness and robes and all of that kind of stuff. But this is Kathleen Lynn. And Kathleen was really, she broke the glass ceiling. She was the daughter of a Church of Ireland pastor from County Mayo. She came to Dublin, and she was a friend of my grandmother's. She was the chief medical officer in the GPO. There were very few doctors left because they were at the World War I. There was a lot of political shenanigans, and she really got shafted by one of our Taoiseachs. But she not only was an Irish patriot, but she founded St. Ultan's in exactly 100 years ago. And she did this against the political will, but it was the right thing to do. So she looked after poor inner city children. So if you want to figure out how to break the glass ceiling and do so 100 years ago, this is the person you need to be looking at. And her, there's a ceremony out in Dean's Grange on Saturday, where her gravestone is going to be unveiled. I'm glad not only to have one of my trainees, but my daughter's here today. She's driving me over to Galway afterwards. And again, you know, it's passing on your knowledge, your support for the next generation. I think that's my job. I'm not too sure if I broke the glass ceiling. It was going to happen anyway. It just happened to be me. But she's the one who did it. So thank you for that. I know it was supposed to be 40 minutes, but I felt that it was more of a personal journey for me and sharing that with you. Thank you. I'm happy to take questions, but I'm not too sure what
We have a roving mic, I think. Anya, thank you.
Hi, this is not really a question. My name's Maureen Duff. I'm one of the fellows here. It was an observation when I was learning way back, as you say, in the early 80s about HIV and AIDS, as it was called then. I went to a presentation by one of the nurse practitioners who worked in HIV, and he was saying that they were trying to get the message out there. So what they did was they put posters all over the hospital about people who may be at risk, and they'd opened up a clinic at night time. So when he went in, and it may well be an apocryphal tale, but I believe it, he said there was two little old Glasgow ladies sitting, and he thought, looked like unlikely candidates. But anyway, brought them in, and they came in together, and he said, why is it you think you might have AIDS? And they said, well, it said on your poster that it's likely to be people that share needles, and we've shared needles for years. So anyway.
Yeah.
Thank you, anyway. But I was reflecting as you were talking about the challenges and the literature around clinicians in management. And do you have a view on that, of clinicians in management and teamwork and different, where should it go, and how do you encourage clinicians in management?
Well, I came from a system in the States where clinicians had huge leadership roles in management. I think the challenge here, and I'm just thinking out loud now, are probably twofold, is the absence of devolution of budget. So while you might manage, you can't really manage without a budget and control over the budget. And secondly, training of clinicians. We do it a little bit, but I don't think we integrate it right from the beginning of undergraduate up into postgraduate. I think we teach it ourselves, and I believe that that's why the interaction with faculties outside healthcare for healthcare professionals in things like business digital health is absolutely essential in how we train our future clinicians, because then you can go in with confidence to your peers if you're talking about IT. So I think first and foremost, though, the devolution of a budget. How can you manage if you can kind of manage people with not, and money is important.
Mary, thank you very much. I enjoyed your talk very much. I think it's probably stronger in infectious disease than most specialties, but what are your thoughts on how to keep clinicians actively involved in research? As the service demands grow and indeed the management demands grow, it would seem that we're getting further and further away from engagement in research.
I would agree, and we certainly don't need to go down the model that they have in the UK where there's very little research done. I think we as a profession need to advocate for a move away from the one-size-fits-all appointments that we have. There are very few academic clinicians in the country, and the only way you can really encourage it is by having different models. So you'd have a clinician researcher, a clinician educator, but when you appoint those, part of the challenge is ensuring that those appointments actually deliver and are accountable for doing it. So I think the model of how we appoint needs to change. Certainly at medical school level, it's absolutely essential that research is part of the core curriculum, that projects need to be done, and they still need to be encouraged for appointments to whatever post that people have. If we lose the integration of research into it, we lose our critical thinking, and what we're doing is just service jobs all the time. And it's the onus on us as a profession to really drive that home with the health service, who are, I won't say research adverse, but they think that's a kind of a luxury item. We only can do it by changing, like, how many academic clinicians we have, 1 to 200 in the country, and everyone else has to do their extra bits, audit, research on the side. So we need to change the model, at least for some of it. That's what I think we should be doing.
Mary, thank you for the talk, which I enjoyed. I liked best your photograph of the Connor Pass. I really think if you can't get up Mount Brandon every year, life isn't worth living. Can I ask you about something which certainly challenges us here? And that's, we can go so far in promoting gender diversity and supporting young professional women in their career choices. And we can influence the training program to make it easier. We can have some influence with the HSE in terms of job plans for people. But there's still a stumbling block, to my mind, in terms of the societal constraints in supporting young professional women as they go out engaging with their careers. And I mean this particularly in smaller hospitals. And, you know, how do we get young professional women to take up challenging roles when they have a whole issue of areas that are problematic in terms of childcare, schooling, and all the things that you would have had to do every summer holiday to sort out your kids? Because as many of us now are in partnerships where both individuals have professional careers, but still it's mainly the female who ends up having to sort out kids and things like that. And so really the question I ask is, do you think us as professional bodies should be more vocal in trying to engage society to fix some of those things that really are problematic for young professionals?
Absolutely. I mean, I had 2 kids, and it really was a juggle. I mean, I had 6 weeks maternity leave, but the structures in the States were better. I didn't have family, but there was the hospitals had daycare, so it was easier in that respect. I think, and I suppose I have a number of female doctors that work with me, and if they ask me for leave in the summer in the STI service, I say absolutely. I say, we'll reduce the clinics, but these people are so good, I want to keep them. And there are times during the year that if you could sort those problems out of, you need more time, parental leave and all of that, during summer, unfortunately, it leaves more work to be done because it is hard to get locums, particularly in smaller hospitals. But we, as a profession, need to push the whole agenda of flexibility on how we work. why shouldn't me, as an infectious disease doctor, be only able to work 3 days a week? I should be able to do that. Many of the specialties that we're in don't need the doctor 5 days a week. And we have been, I suppose, as a group, probably need to be more forceful in pushing flexible training. You know, you might say that, but a lot of it is flexible working. I mean, if you go to any other, I see Aisling works in one of the big consultancies, and they can work from home. Obviously, you can't do that with some of the patients, but you know what I'm saying is that there's a culture of responding to the needs of the millennials who are different than us. And I think what I found really helpful is bringing somebody in from outside, in from business, telling us how they adapt their work environment to suit their workforce. And while you can't do a lot of, you can't obviously say, you know, I'm, you know, taking some days off in surgery maybe, or some other things, but there can be structures put in place where it can be done. But we practice the very same way as we did 30 years ago when I was training. We haven't moved with the times. And the only way of doing that is looking elsewhere and seeing what they're doing. We can't do everything they can do, but we can do a lot of things. And I think it's engaging, getting ideas, but then pushing the agenda with the HSE, because we can't be the same as we always are. It has to change, and that's why people are going away.
Mary,
yes.
Mary Carney from the Faculty of Nursing. You mentioned the clinical nurse specialist earlier. I'd like to know, where do you see the role of the advanced nurse practitioner in the care of infectious diseases, or in midwifery, the advanced?
Well, I can tell you one area straight up front. I think that STD clinics should be run by nurses. I don't think they need to be run by doctors, and they need to be out there in the community. And the nurses I have in the STI clinic, the clinical nurse specialist, essentially, you know, runs the show. And with a lot of chronic diseases that we see, I'm not a specialist in diabetes or rheumatological diseases, but certainly within infectious diseases, HIV medicine has gotten very straightforward now. And I think the advanced nurse practitioner, in particular when it comes to drug prescribing and so on, should be well able to run an HIV clinic with backup for more complicated, I mean, not that they can't handle, but they can identify complicated patients and look for help from their medical colleagues. But in my opinion, I think that clinical nurse specialists and advanced nurse practitioners are underutilised to deal with a lot of the issues that we have here, particularly when it comes to care of the elderly, medicine. I would absolutely, I mean, if my nurse comes to me and is worried about patient, I know that there's a problem there. And I think pushing those roles for chronic disease management, particularly at the interface of hospital and the community, where you can keep patients where they should be out in the community, they're absolutely essential and underused.
Thank you.
Thank you very much for the really interesting talk. I suppose one of my questions is, sorry, I'm Enda Kelly. I'm the Director of Nursing with the Prison Service and a Fellow with the faculty here. You've mentioned about having been overseas and come home and set up services where you would, you know, obviously take the idea from abroad and bring it back and try and make it work here. And when you look across the world, in the Americas, in Australia, there are Irish people leading up absolutely fantastic services in all the healthcare domains. When a lot of us, and I trained overseas and spent most of my career overseas, when we come back, it seems that there's some kind of a stumbling block, or there's a glass ceiling there. And my own personal kind of opinion is that it's around how civil servants and politicians perhaps don't see the progress and how things can be and how we can be more imaginative. What are your thoughts on how we influence that change? I mean, lots of us do it all over the world, and then we really get stuck when we're here?
Yeah, you have to be fairly resilient when you come back and very persistent to get things done. And it's not all about money, because I think that the money could be spent better. I think that certainly at probably hospital management and maybe healthcare management, they need to go elsewhere to see that this really works. When you're frontline, you really get good ideas, and you have, if you're allowed, the opportunity to make things a lot more efficient. There's been quite an increase in managerial level there, which I think has made things even more difficult for us to get things done when you're overseas. How can you influence it? I think what I used to always do is have to go around the scrum. I mean, I sometimes just did things and then looked for forgiveness afterwards. But we shouldn't have to do that. It's the culture, the mindset of, as you said, the civil service or managerial, many of whom are, they're good. It's just you really have such a hard time selling them how things could be done better, more cost efficient, with better patient outcomes. And I think, look, the simple message I would give, and I gave it to Paul Reid, is listen to the frontline staff. I think it's, he was saying that it was hard for him to get from where he is down to the kind of hospital manager level, which I understood, and then the parallel for us is getting from the hospital senior people to the frontline staff is really challenging. And it's listen to the frontline staff. They have good ideas. They deal with the issues, and whether that's people in community, in the prison services like you, or in the frontline emergency department and so on. For those, and most of us are flexible and are there to do the right thing for patients. But I think it's keep giving the message, listen to us, we're frontline, we know what we're doing.
Professor Horgan, thank you so much. And on behalf of the faculty, we'd like to give you a little small token of appreciation. Thank you so much.
Thank you, Michael. Thank you.
And with that, our evening comes to an end. I'd like to take the opportunity to thank Catherine Mulvaney and Anya to my right for your superb preparation and help throughout this. It's wonderful to have a little baby in the audience. Obviously, the faculty are thinking of our membership and fellows of the future, so thank you for bringing your little baby. There's drinks and refreshments outside if you've time. And once again, Professor Horgan, thank you so much, and safe journey with your daughter. Take care. Thank you.